اوكي طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I'd like to welcome everyone once again in the Pediatric GI Academy platform. We took a short break during the summer and now we are coming back with a star. Really, I'm honored to introduce the speaker for tonight's lectures. Actually, he's my friend, my brother, Dr. Omar Alharbi, we are already missing him actually at King Fahd Medical City. As you know, Dr. Omar, he's a consultant, pediatric gastroenterology, and he is one of the few actually consultant who is certified in advanced endoscopy. He will speak to us in the next 45 minutes about EUS in children and adolescents. First of all, Dr. Omar, thank you for accepting my invitation, although in short notice, and we are really excited to hear your lecture. The floor is yours. تفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning and good evening, and depends on where you are. I would like to start by thanking Dr. Muhammad. It's really exciting to see Pediatric GI Academy taking off as compared to, I mean, you just started last year, and we saw so many great lectures. And I'm happy to see some audience from the US, including some potentially future fellows. I see my friend Fernando Medina from San Luis. This is really fantastic, and I'm sure in the future this Pediatric GI Academy will continue to grow and expand. It's really exciting to see. Okay, we'll go ahead and start with the talk. Okay. Can you hear me okay, Mohammed?
Yes.
Okay, sounds good. So just a quick outline about the talk. I'll start with some history about endoscopic ultrasound, how it all started, some equipment review, what equipment do we have in the endoscopic ultrasound field, what are the clinical indications to do this procedure, and some data on safety and efficacy in children. So EUS really started as a more of a technical curiosity, whether just to take kind of images inside the GI tract and see if these images are helpful. And now they expanded to a huge field with a significant impact. It all started in the 1980s, where the first echo endoscope was developed by Olympus, which is a Japanese company. However, this first echo endoscope was of limited utility because it was just an imaging technique rather than a technique that we use today to get diagnosis and to do interventions. Initially only started with what we call a radial scope, and I'll show some pictures. And then in the 1990s, Pentax developed the linear echo endoscope, and that really changed the whole field, since this linear echo endoscope can allow us now to do more interventions. I like this slide because it shows that with any new technology, you really just need to be patient. It started in the 1980s, and it took approximately 15 to 20 years for this new technology to really take off and be helpful for patients. So if you're more into the innovation field, this slide should be imprinted in your mind. Just be patient. So equipment review. These are the two echo endoscopes that we have. An echo endoscope is basically a scope with an ultrasound machine or ultrasound probe at the end of the scope. On the left-hand side, you see the radial echo endoscope. This gives you more of a cross-sectional imaging. So it's like doing a CT scan, a cross-sectional imaging, while a linear echo endoscope gives you more of sagittal or coronal images. Why this is important? Because the linear echo endoscope on the right side, as you can see, the biopsy channel or the working channel is in the same plane as the image. And this really changed the field, and now we're able to do a lot of interventions. While the radial echo endoscope on the left side is useful for only imaging. You cannot provide any interventions or diagnostic pathology acquisition. These are the two scopes that we have. The same thing. On the left-hand side, you see the radial echo endoscope, and then on the right side, the curvilinear ultrasound scope. What about EUS and pediatrics? We know that EUS in adult medicine is already very well established. It's being used for many interventions, many diagnostic procedures. In pediatrics, comparatively, we're still a small field, but definitely evolving. We're finding more and more useful interventions that we can provide with endoscopic ultrasound. And then it's safe to use in pediatrics for kids who are 15 kilograms or more. Why this is important? Because it's the largest scope that we have. Especially the linear echo endoscope is 14 millimeters, so which is larger than a colonoscope. But definitely there are some case reports with much smaller children. EUS been done, for example, for a 1-year-old who's way below 15 kg. However, in my practice and most endoscopists, they take this 15 kg limit as kind of the safety limit for EUS. So how does EUS compare to a CT scan or an MRI? You might ask yourself, why do an endoscopy while we can get just a CT scan or an MRI? It's definitely a legitimate question. We know that EUS definitely needs anesthesia, especially in kids. You need general anesthesia. However, it has no ionizing radiation as compared to a CT scan. And really the main difference is that it can be diagnostic and therapeutic in the same setting. And I'll go through some examples. This is really the main difference as compared to a CT or MRI. You can see something, you can biopsy it, or you can intervene on it in the same setting. Also, it gives us very high resolution images because of the proximity of what you're examining. For example, if you're examining the pancreas, you're right there, right at the posterior wall of the stomach. You can see the pancreas very close. So it gives you very high resolution images. And it's a dynamic study. So as compared to a CT or MRI, right, you get images and then it goes to a radiologist and the radiologist reads it. And EUS is a dynamic study, meaning if you see something abnormal, you can move around, you can move the scope around and examine it further and further. It's not a still image. What about the clinical indications? This is definitely an expanding field. The main indications for EUS are primarily biliary, some pancreatic indications, luminal indications dealing with the lumen of the GI tract, and some extraluminal indications. And I'll go through those one by one. So starting with biliary indications, choledocholitis is the most common biliary indication for endoscopic ultrasound, followed by biliary access, and I'll go through some examples, and EUS-guided gallbladder drainage. So starting with choledocholitis, EUS can give you very clear images of the common bile duct and the surrounding structures. As in this picture, you can see this is a radial echo endoscope that shows the CBD that's outlined there. The whole CBD is showed, and you can see a stone in the middle of this, or a filling defect in the middle of the CBD. So you can see how close these images are. These are other examples of choledocholitis. This is a linear echo endoscope. You can clearly see a filling defect in the middle of this tubular structure, which is the CBD. And also on the right-hand side, you can see multiple filling structures within the common bile duct. This is a nice picture that shows the difference between a normal CBD and an abnormal CBD. These are radial endoscopic ultrasound images. It shows the CBD nice and thin. It's not very dilated as compared to a portal vein on the left side image. While on the right side image, you can see a clear filling defect with shadowing. So it looks like, so you can see a stone with shadowing behind the stone. This is a clear indication this patient needs the stone to be removed by usually ERCP in the same setting. So moving from choledocholitis to biliary drainage or biliary access, these procedures are useful when you cannot access the biliary tree, meaning there is a contraindication to ERCP, or ERCP is not able to reach the bile duct. We have several procedures in this field, starting with endoscopic ultrasound guided choledochidodenostomy, which is a long word for meaning just creating a fistula between the duodenum and the common bile duct. And I'll show some images. So this is a choledochidodenostomy. Also, you can create a connection between the liver and or the biliary tree and the duodenum, or the biliary tree and the stomach. All of these are needed when ERCP is not possible, either due to an obstruction or malignancy in the distal bile duct. And this is a very nice image that shows the difference between these procedures. So if you have, for example, this patient with a tumor at the hilum of the liver, so if you do ERCP, the wire just keeps coming back. You cannot access the whole dilated biliary tree in the top. You can see the liver with the dilated biliary tree. So on this, in image A, this is hepaticogastrostomy, meaning creating a fistula between the stomach and the intrahepatic biliary tree, and placement of a metal stent. While in image B, you can see creating the same thing, a connection between the duodenum this time and the intrahepatic biliary tree, because this tumor or blockage or abscess blocks the access from the bile duct. And in image C, you can see both procedures are done, access from the stomach and from the common bile duct. This is another example. If you have a dilated biliary system or something blocking the distal bile duct, we can create a fistula between the duodenum and the bile duct that is not obstructed, and a stent can be placed. This is exactly the same thing. So image A shows a very dilated common bile duct. ERCP was attempted and not possible to go inside the bile duct. In this case scenario, in image B, you can see the scope. This is the ultrasound scope in the duodenal bulb. The CBD was visualized and accessed through that way, through the duodenal bulb. And then after we get access to the biliary tree, we can place a stent and relieve the obstruction that way. This is creating a hepaticogastrostomy. So this is a connection between the biliary tree, the intrahepatic biliary tree, and the stomach. Same thing. We can examine the liver. We see very dilated in image A, very dilated intrahepatic bile ducts. And then through image B, you can see the ultrasound scope at the top right with the needle sticking out, getting access to the intrahepatic bile ducts. And then the tract is dilated and stent is placed. So this stent, you can see an image D. This presents a stent from the stomach to the intrahepatic bile ducts due to obstruction of the distal bile duct that cannot be accessed otherwise. So you might think this is all done in adults. Why do we need it? There are actually some pediatric cases in the literature. This is one of them. This unfortunate situation is a 7-year-old child who was run over by a truck. This caused a very severe liver injury, a grade 4 liver injury with biliary ascites. So this caused a lot of bile leak. ERCP was done for the bile leak, but the patient continued to have biliary ascites and leak due to disruption of the left hepatic system. So these are some images. You can see the liver is completely destroyed, the grade 4 laceration, some laparotomy on the right side, and the initial ERCP showing the arrows in picture D that shows the bile leak. So in this case scenario, they only were able to see the right-sided intrahepatic biliary tree. They could not see anything on the left side, which means the left side is completely lacerated or disconnected. So the patient continued to have a leak from that disconnected left intrahepatic biliary system, which led them to perform this procedure. Basically, they did an endoscopic ultrasound, and this is in picture B. You can see the ultrasound scope in the stomach, and by the needle, we were able to access the left intrahepatic biliary tree. And then a stent is placed that way, and the patient did very well with no further bile leak inside the peritoneum. And a later stage, a patient had surgical intervention. So moving from choledocholytitis to biliary access to the last biliary procedure is gallbladder drainage. These are very rarely done in kids, but they can be helpful if the gallbladder cannot be removed surgically because of contraindications to a surgical intervention. Basically, a poor operative candidate. Those are patients with a very high anesthesia score, for example, score 4 or 5, patients with severe thrombocytopenia, advanced malignancy, or coagulopathy. If they have acute cholecystitis, the outcome from a surgical intervention could be poor. And this is an alternative to a percutaneous drainage. So in this situation, we can access the gallbladder that way. So the gallbladder cannot be removed surgically in this scenario because the patient is a poor surgical candidate. We can examine the gallbladder from the duodenum and create a connection between the duodenum and the gallbladder for the drainage of the pus inside the gallbladder, and usually patients do well. This is a relatively rarely performed procedure with a high complication rate. So we don't do it unless we really have a good reason to do it. So we finished the first part. That's the biliary indications for endoscopic ultrasound. We move to the pancreatic indications. One of the most common indications are pancreatic fluid collections. And then we can do EUS for chronic pancreatitis, pancreatic lesions, and autoimmune pancreatitis. This is the Atlantic classification. This is a famous picture whenever you have a patient with, let me check my time. Okay, we're doing okay. Whenever you have a patient with a pancreatic fluid collection, try to Google this image, the Atlantic classification. It will help you. It will help you to know what exactly to be done about the patient. What's your diagnosis? So if the patient is very fresh after pancreatitis, less than 4 weeks, the most common is the first one on the left top part, the acute peripancreatic fluid collections. These are the regular fluid collections that we see with moderate and severe pancreatitis. And then on the right side is the more severe complication, which is acute necrotic collection. If these collections do not resolve with time, they can, the first one, the acute peripancreatic fluid collection, can develop into a pancreatic pseudocyst. And the second one, the acute necrotic collection, can develop into a walled-off necrosis. Usually, there's about 50% chance these might resolve spontaneously without intervention. However, if the patients are symptomatic or they continue to be in pain or with symptoms of gastric outlet obstruction, because the pancreas is just behind the stomach, these fluid collections can press on the stomach and cause gastric outlet obstruction symptoms. So if the patients become or continue to be symptomatic, these fluid collections need to be drained. In the past, before EUS, they used to be drained either by surgical intervention or by a percutaneous drainage with interventional radiology. However, now EUS is the gold standard for these patients, as it's a minimally invasive procedure. It's internal drainage without any external tubes or a surgical procedure. This is an example of a pseudocyst. You can see in the top 3 pictures, they're all very huge fluid collections, and usually these are large fluid collections. I've seen 10 centimeter, more than that, fluid collections. And then in picture D and E, you can see creating an axis between the stomach. So it's a cyst gastrostomy from the cyst to the stomach. And then a stent is placed with, this is in picture F, you can see the fluid from the cyst draining into the stomach, and it just goes through the GI tract, and the fluid collection is relieved that way. This is a video. I can start the video and I can comment on it. So this is Dr. Ken Ben Moller. He invented this special stent called an Axios stent. So in this part of the video, he punctured the cyst with the endoscopic ultrasound and the tool. And now he moved from ultrasound image to an endoscopic image. He's just saying he doesn't need ultrasound anymore on this after this stage, and he's kind of moving away, deploying the stent, and you can gradually see the stent being deployed from the stomach to the cyst. Immediately you see a gush of fluids, the gush of fluids coming from the cyst to the stomach, and it's usually a very satisfying procedure. We have drained patients more than a liter. Within a few minutes, you can see a lot of fluids coming out. And usually patients feel very, very well right after the procedure. So moving from pancreatic fluid collections to chronic pancreatitis, EUS can give us very detailed information about the pancreatic parenchyma and the ductal structures. It can show subtle features of chronic pancreatitis that can be missed with regular imaging, like a CT scan or an MRCP or an MRI. And recent meta-analysis shows that EUS is superior to MRCP and CT scan and abdominal ultrasound in chronic pancreatitis. This is the criteria we use for chronic pancreatitis when we do an EUS. We use either the Rosemont criteria or the conventional criteria, and we don't need to talk about this, but it's just to show that we have specific criteria to diagnose chronic pancreatitis using endoscopic ultrasound. And chronic pancreatitis is definitely much more common in North America as compared to the Middle East. I mean, and in my experience in 3 years in Saudi, I haven't seen a single pediatric patient with chronic pancreatitis, but only a few months here we can already saw a few patients. Definitely hereditary pancreatitis is much more common in the West. So we can see here how does chronic pancreatitis look. The top 2 images, A and B, this is the normal pancreas, shows normal duct with the yellow images, and a normal kind of homogeneous pancreas in picture B. While in picture C and D, you can see a very different situation, a very dilated pancreatic duct in picture C with an intraluminal, intraductal stone. And in picture D, you can see a very different pancreas. It's kind of ugly looking, heterogeneous with a lot of foci inside the pancreas. Pancreatic lesions is also another indication for endoscopic ultrasound, and mainly is to obtain a tissue diagnosis. All of these are relatively rare in pediatrics, except SPN, or solid pseudopapillary neoplasm. I definitely saw cases in Saudi and cases in North America. Typically a young female. The last case we did earlier this year in Saudi was, I think, an 11 or 12-year-old female with a pancreas mass. She presented with abdominal pain. We did EUS and obtained a tissue diagnosis by getting a fine needle biopsy. This is an example of FNB done for a pancreas lesion. You can see in picture A and B, this is the needle going through the pancreas lesion to obtain a tissue diagnosis. And this is an example of tissue being biopsied from the pancreas. We can do either FNA or FNB. It's just a different needle that can be used. So the last pancreatic indication that I'll talk about is autoimmune pancreatitis. We know that autoimmune pancreatitis can present as acute recurrent pancreatitis, or chronic pancreatitis. It could be IgG subclass 4 positive or negative. The treatment is corticosteroids. EUS is helpful for visualization of the features and to obtain, more importantly, to obtain a tissue diagnosis. Before committing a patient to steroid therapy, we actually have criteria whether you can diagnose the patient without a biopsy or with a biopsy. And the adult criteria, they always do EUS and get a biopsy diagnosis. However, in little children, you can avoid sometimes an EUS if you have very classic features of autoimmune pancreatitis. So you have a CBD stricture, sausage-shaped pancreas, and I will not go into the details, but sometimes you can avoid doing an EUS and just get imaging features. So these are some images of how autoimmune pancreatitis can look like in EUS. Picture A shows a very enlarged, very bulky pancreas. Picture B shows lobularity of the pancreas. And below we can see elastography. Elastography can tell us how stiff is the pancreas. Just like doing a liver elastography by regular abdominal ultrasound, it can be done also with EUS, and it shows you stiffness of the pancreas. And this is a sign of chronic pancreatitis and autoimmune pancreatitis. So moving away from biliary indications and pancreatic indications, now we reached luminal indications. EUS can be helpful to diagnose an esophageal tracheobronch. This is not tuberculosis, this is tracheobronchial remnant. Those are patients with severe esophageal or congenital esophageal strictures that you keep dilating and dilating and they don't get better, or the stricture keeps coming back. You might suspect a tracheobronchial remnant. In this case, either a CT scan or an EUS can be helpful to see if there is cartilage inside the lumen of the esophagus. So this cartilage can be easily seen with EUS, and once you diagnose that, they go to surgery for resection of that segment of the esophagus. EUS can also be done for gastric varices. If you have a patient with gastric varices that had bleeding, EUS can be done for coiling of these varices, and I'll show some pictures. This is more of a research rather than an actual clinical practice, but for EUE, EUS has been done to examine the thickness of the esophagus, and that correlates with how bad the inflammation is. But it's not being routinely done for clinical practice, but I've seen some research papers talking about EUE and EUS. This is very rare in kids, but it also can happen. Gastric and duodenal subepithelial lesions typically happen in the adult population where they undergo endoscopy and they see a bulge in the stomach or the duodenum. And to diagnose this, whether this is a malignant lesion that needs to be resected or something else that is benign, EUS can help with that. It can give you features of malignancy or whether you need a tissue diagnosis from these lesions. This is an example of gastric varices with coiling using EUS. In picture A, you can see very huge gastric varices. In picture B, this is the ultrasound image showing very dilated varices. In C, you can confirm that these are actually vascular lesions by doing a Doppler at the same time. And then picture D, you can see a needle going through these varices, and then coil is deployed to obliterate these vessels. EUS also can be done for extraluminal indications, like doing an EUS-guided liver biopsy. However, the consensus now is if you just need a liver biopsy, typically interventional radiology is probably better. However, if you need a liver biopsy and endoscopy for some reason, to do both at the same time is very possible, and it might be better than doing two procedures. One example is, for example, a patient with, let's say, autoimmune liver disease or autoimmune hepatitis. They have esophageal varices. You'll go inside and examine the varices or band them. At the same time, you can get a liver biopsy to check activity of the disease. Patients for cirrhotics, you can also do the same thing. Examine the esophagus or the stomach for varices, and at the same time, you can get an EUS liver biopsy. EUS also can be done for to obtain lymph node, large lymph node biopsies for lymphoma. Portal pressure measurements. This is relatively new in the last maybe 2 to 3 years or so. This is being done to instead of an IR intervention where they have to cannulate vessels to get portal pressure measurements. It can be done by EUS. However, it needs definitely special equipment and special training that I'm not capable to do so far. EUS also guided fiducial placement. These are also mainly in adult population, but we might see indications in the future in the pediatric population. Fiducial placement is to place very tiny metals for typically malignancy, for them to be targeted by radiotherapy by radiologists. So it's something to fix for the radiologist to see where exactly the lesion is for targeted radiotherapy. So now we're done with the clinical indications for EUS. What about data in pediatrics? Definitely several papers in the pediatric population talking about EUS. This paper is from one of two of my mentors and friends, Dr. Travis Peaster and Dr. Quinn Liu. They looked at their EUS experience at Children's Hospital Los Angeles and Cedars-Sinai also in Los Angeles. They examined all patients who underwent EUS, and they saw they analyzed what the indications were and what's the outcome. So in their cohort, the main indications were pancreatic indications. And you can see here several indications moving from pancreatic fluid collections, acute pancreatitis, chronic pancreatitis, pancreatic mass for FNB, and then followed by biliary indications. And then they looked at whether these procedures were done for diagnostic purposes or therapeutic purposes, in their cohort, mainly diagnostic purpose, and 9 cases were for therapeutic intervention. And in about 18% of their cohort, the EUS actually changed the management. It avoided unnecessary ERCP. So these patients, for example, they come in with either cholangitis or just jaundice, elevated LFTs. You get an ultrasound, you see a dilated CBD, for example. And then we can do EUS and we can see if the stone is actually still there or not. And this could help you to avoid the RCP. If you do an EUS and the stone has passed already, you don't see any stone in the CBD, you can just stop there and avoid going through a more involved procedure with definitely more complications. ERCP is associated definitely with more complications. So you can definitely avoid ERCP by doing an EUS just before the procedure. And they did some also patients with pancreatic fluid collections, and these patients avoided more surgical intervention or more invasive therapy. They had only 1 patient who had a complication out of 98 patients, which is definitely a low percentage, a patient with GI bleed. And I looked into the details of this case. The patient actually had anemia after the EUS, but not confirmed GI bleed. The patient did not have any obvious signs of GI bleeding. However, they reported it as a possible complication. This is another paper from a great paper from India that they did a large cohort of patients. I think 85 patients. And you can see several indications for the procedure where the patients had abdominal pain that cannot be otherwise figured out or investigated from other images. Jaundice, cholangitis, and pancreatic fluid collections, and several other lesions or indications. And they looked at whether the EUS had a meaningful impact. So out of 85 patients, 69 patients, the EUS had a meaningful impact, whether from a diagnostic or a therapeutic standpoint. So in conclusion, EUS is safe and effective in children. It can provide multiple diagnostic and therapeutic indications and interventions. In our field, mainly pancreaticobiliary indications are the most common. There's definitely room for more research and innovation in EUS, especially in the pediatric population. These are my references, and thank you all for listening and being here.
Thank you so much, Dr. Omar, for this really informative lectures. It's really advanced for a regular gastroenterologist to hear about these EUS. Maybe we will open the floor for the question, but before that, if I can ask you, Dr. Omar, you mentioned in the study that been done about like 100 patients underwent like EUS. Only 1% gets possible GI bleeding. So it looks like it's a very safe procedure. So what's the expected complication you are looking for with this type of procedure, especially if you are putting stents, either like needles and etc.?
Correct. That's a good question, Dr. Mohammed. The most common, let me stop sharing my screen here. So if EUS is being done only for diagnostic purposes, this is very safe since you're only taking a look with images. If you do it for little kids, 15 kg or less, definitely chances of perforation and stuff, more dangerous stuff is definitely there. However, it's not reported in the literature. If you're doing more of an intervention, like sticking a needle for a biopsy or to get biliary access, the chance of complications are definitely more. We have seen pancreatitis after getting a biopsy for autoimmune pancreatitis. I've seen significant GI bleeding or bleeding inside the pancreas after biopsies. So it has to be done definitely with some experience.
Perfect. So I have here one question from the audience. Can EUS detect early malignant transformations in biliary cyst?
That's a good question. I'm not aware of any data that says that, but definitely you need more histology. If you have a cyst, if you have a biliary cyst, you can see if there is a lesion that's starting to develop, a visual lesion, you can easily see it with EUS, and you can biopsy it. However, if it's only a superficial transformation to malignancy, EUS will not be helpful. And with the choledochal cyst, for example, if it takes years and years for malignancy to develop. So if you have a patient with choledochal cyst, they usually should undergo surgery, and they rarely have cholangiocarcinoma, for example. But if you leave them alone for a long time, this is definitely a risk.
Perfect. Dr. Omar, since you started doing this EUS, what is the top 3 indication for the US that you've encountered?
Definitely, the top one is choledocholithiasis. You have a CBD stone, is to confirm the stone that stone is still there before doing an ERCP. This is the most common, followed by chronic pancreatitis. The third one, I would say, probably autoimmune pancreatitis or acute recurrent pancreatitis, is to look for features of chronicity or to obtain a tissue diagnosis.
Perfect. Have here another question. What do you think is the projection of EUS in children regarding indication, availability, training, etc.?
Yeah, it's a big question. Definitely, it's so the main problem we have in pediatrics is the size. EUS scope, as I mentioned, is a huge scope, so it's easy to run into trouble if you do it for very little children. However, if innovation comes up with new technology or smaller scopes, I can see in the future new indications to do endoscopic ultrasound. For example, and I was actually just thinking about this morning before the lecture. How can EUS be more helpful? For example, kids with suspected biliary atresia, if we have very small scopes that we can go inside the intestine of a child who's a month old, for example, and see if you can examine a CBD, for example. Can you access it with a needle? Can you do a cholangiogram in that technique? So now we know percutaneous cholangiogram is being done for biliary atresia. So we might be able to do that in the future for kids instead of sticking a needle from the outside or doing an intraoperative cholangiogram. Why not to do it from internally? So these are the things that we need to think about in the future.
Okay, there's another question from Fernando. What platform brand do you use at CHLA? Do you modify the adult technique at all, especially epidudinal apex and papilla, to minimize the risk of perforation?
Yeah. First of all, thank you, Fernando, for being here. Fernando is a colleague. I think we did fellowship in the same year, in the same class, and he's always interested in endoscopy. So we use Olympus scopes at CHLA. Both the radial and linear scope are Olympus. Techniques can be modified in very little children as compared to adults. Usually the papilla could be a little bit more inferior. So we typically need to push the scope a little bit further down the duodenum. And the duodenal apex is the same view as an adult patient. But definitely very careful maneuvering as compared to an adult patient. Careful maneuvering and reducing the scope. All of this needs to be much slower, needs to be done much slower in kids as compared to an adult patient.
Perfect. Probably have the last question. Good question here, Dr. Omar. Do you remember, like, what is the most successful story that you encounter using a therapeutic EUS with the patient that you dealt with?
Yeah, thank you for this question. Definitely the most satisfying EUS intervention is a pancreatic fluid collection. I remember at KFMC, we did 4 or 5 patients where I remember one of them is a 12-year-old female who had a disconnected pancreatic duct. So she had a bicycle injury, handlebar injury. So she's basically with a bicycle with a handlebar turned around and caused a blunt trauma to the pancreas. And when you have a blunt trauma to the pancreas, you have a disconnected duct. The pancreatic duct is transected in the middle, and they develop this huge pancreatic fluid collection. She was in severe pain, very distended abdomen. You can see the cyst only by inspection, right? You can see a huge abdominal girth. And immediately after the EUS with drainage with the cyst, right after the procedure, no pain. You can see stomach is flat, and this is the first time for months this patient is free of pain. So this is probably the most incredible intervention that we can do with the EUS.
Okay, great, Dr. Omar. I think this is the last question. Thank you again for being with us. It was really a great lecture. We learned a lot from you. And hopefully, inshallah, we'll see you in different time with other lectures and advanced endoscopy, inshallah.
For sure. Thank you, Dr. Mohammed, for this great invitation. I'm very happy to be here and to see some of our previous fellows and some participation from the US. This is fantastic.
Yeah, thank you, inshallah. See you next time.
All right. Thank you. Thanks. Bye-bye.